Hi friends, Dr. Harsha here from Vice Academy. Small video about bladder injuries, important concept and frequently asked MCQs from this concept. So, most common is iatrogenic injury, and most of the injuries occur in the hands of a urologist, especially while doing surgeries like transurethral resection of bladder tumor or sometimes during TURP. And common surgery other than urology surgery is hysterectomy. What happens is in hysterectomy, when they are trying to develop a plane between the uterus and the bladder, that is the most common step where the bladder can get injured. And the most common site where bladder injury is seen is at the dome of the bladder. So this is about the most common things. Other things, other surgeries where bladder can be injured is any pelvic surgery or any surgeries which is having deep adhesions or some incontinence surgeries. So these surgeries, there is a chance of injuring the bladder. So there are two types of bladder injuries. One is a intraperitoneal rupture, and other one is extraperitoneal rupture. So what is intra and extraperitoneal is, in the name itself speaks. In extraperitoneal rupture, the peritoneum is intact. So whatever injury has occurred, the urine doesn't seep into the peritoneal cavity. So in an intraperitoneal rupture, it is vice versa. All the urine now seeps into the abdominal cavity, and there will be chemical peritonitis, urinoma, and patient will be in severe sepsis. So comparing between intra and extraperitoneal can be managed conservatively. Extraperitoneal rupture is a much milder form of bladder injury. So how to actually diagnose a bladder injury is, the best one is to do a CT cystogram. So CT cystogram means what they do is, you have to fill the bladder with diluted contrast material. You have to take at least 50 ml of contrast and dilute it to 300 to 400 ml, and you infuse the contrast through a Foley catheter. So once you start infusing the contrast, a CT scan is plain CT is done. So in this plain CT, you can appreciate if it is an intraperitoneal or extraperitoneal rupture of the bladder. You can find a rent in the bladder dome or in the bladder wall, by means of which you can confirm that there is a injury. Apart from that, you can also see outlining of the bowel loops. You can see the contrast entering into the abdominal cavity. You can see the contrast outlining the under surface of the liver. So if these things are there in the CT cystogram, then it means you are dealing with a intraperitoneal rupture of the urinary bladder. So as I mentioned earlier, extraperitoneal rupture can be managed conservatively with Foley catheterization for 2 weeks. And then what you do is, again you instill contrast, see if it has healed well, and then you remove the Foley catheter. Likewise, the same management principles cannot be applied for intraperitoneal rupture, because urine is leaking into the abdominal cavity. So the best modality of management here is to explore, go inside, find out where the rent is, and close it. So previously they used to advocate 2-layer closure. Now a single layer closure, but a good tight, watertight anastomosis. If it is a watertight closure is done, then a single layer closure will suffice. It is done with a absorbable suture, preferably a 20 vicryl, and a Foley is left in situ for 2 weeks. Like any other grading system, the AAST has also got grading system for urinary bladder. So another key point, last point that we need to remember is, usually extraperitoneal ruptures we do not open and do the repair. But in case if the surgeon is operating and performing some other surgery, or like fixing a fracture, or if there is any blunt trauma in the abdomen and opening the abdomen for something else, so as a additional procedure, we can repair the bladder also at the same time. So this is about intra and extraperitoneal rupture of bladder and its management. Thank you.